of enjoy each other's company briefly. Now comes the great moment, right? I'm Jamie Jensen. I'm currently the board chair of the Open Door Foundation. Laura was a former board chair. She has been a source of leadership for Open Door for almost 15 years. Do I have that right? Yes. And you've been such a wonderful role model for me, so thank you. Having you and Sue in the room, both of you former chairs, makes me feel really, really happy. Hi, Sue. So Bob and Laura, thank you for hosting us tonight. This has been absolutely fabulous. We so appreciate it. Yay! So people always make me do this when we start something, and it's like, so why Open Door? Why do you care? So Open Door is more than the amazing clinical professionals. Open Door is an integrated health home. I've learned that, it's my elevator speech. I live with it. So all of the clinical and administrative staff come together to provide the full range of health and wellness services. So it's not just like going to the doctor. You go there and everything is tackled. And it's kind of amazing. But what impresses me most, and I learned this for anybody who wants to get more involved with Open Door, what impresses me most is that through our history, right, 50 years, the leaders, the Lindsays and the Darrens and so many other leaders, have built a lasting community of partners. They are a beautiful partnership model with government, nonprofits, the corporate sector, and so it's our leaders working every day that make Open Door so successful because they really, really do get that we're strongest when we work together. And so you all are here because you're part of our community of Open Door. And Laura and Bob are inviting you into our community. Now I'm gonna shut up and I'm gonna look at Lindsay, our CEO, and say, Lindsay, I'm so excited to talk about this topic. AI, couldn't be cooler. For all of you who don't know, Get Your Economist is on the cover this week. My husband just texted me, he goes, AI in healthcare is on the cover of The Economist. So there you go. It's a topic of the moment. Lindsay, thank you for having us.
Thank you, Jamie. I'm Lindsay Farrell, and I'm the president and CEO of Open Door Family Medical Center and Foundation, where I've worked since 1986. Hard to believe.
Whoa.
I know, very long time. I'm pleased to tell you a little bit about Open Door and the very important work that we do. We are what's called a federally qualified health center, but we're the family doctor, Dr. Wu, and we're the family dentist for tens of thousands of people living and working right here in Westchester, most of whom are low income, most of whom are below the federal poverty level, many of whom have no insurance or are covered by Medicare. Many of these people are our neighbors in Ossining. We have sites in Sleepy Hollow, in Brewster, in Portchester, in Mamaroneck, did I forget any? In Mount Kisco. And so we've grown through the years. We've been in the business of health equity for 50 years. It's the work that we do. And so just as a point of reference, I should tell you that we employ 150 licensed independent practitioners. Those are physicians, dentists, social workers, nurse practitioners, physicians assistants, psychiatrists, right, midwives. So we have a range of staff members who are supported by about 350 other staff members. And our operating budget is about $63 million a year. And we have a wonderful model of care that Jamie talked about, and I'm sure we'll get into it in this presentation. So really, first and foremost, thank you, Laura and Bob, because we wouldn't be here today without them and their leadership. And Laura's been such a long-standing, a wonderful friend, wonderful board member, and Bob is just the greatest. And their son Sam is here too. And so thanks to the moguls, we're here doing this today. This is really the inaugural Spotlight Series event, and as we were thinking about, how do we reach more deeply into the community, we thought, well, if we could talk about something interesting that might be informative to the people who join the event, we might all learn something, and most importantly, as Jamie noted, we get to bring in some cool and interesting people. So I'm looking at Pablo, I'm looking at Vasco, and I'm really very excited to have this dialogue today. They are truly experts in the field. So let me tell you a little bit about Pablo, and Jan Fisher's here, and Jan and I think we met Pablo at some of these Westchester County functions. Pablo works for Slalom Consulting, But, he's such an interesting healthcare professional, and I think it's so cool because he's from Ecuador originally. That's not in your bio, but I'm taking the liberty. And, what's so fascinating in Asane, so much of our patient population actually hails from a certain part of Ecuador, and Pablo and I were talking about this. He's like, that's where my grandmother's from. Darren, you didn't know this. He's from Giron, right? And so, he has a unique perspective on the work that we do. So Pablo is the Director of Client Services at Slalom Consulting. He's a highly accomplished technology executive with nearly 2 decades of expertise in the dynamic realm of digital transformation. In his current role at Slalom, which is an amazing company, by the way, and I'm so happy that you're helping us navigate some some challenging efforts. Pablo plays a pivotal role in assisting brands in formulating and executing effective marketplace strategies supported by the right technology roadmaps. Prior to Slalom, Pablo held executive positions at Nature's Bounty, the prominent manufacturer, retailer, and wholesaler of vitamins and supplements, and at Elsevier, I didn't know this, which is a leading global publisher of scientific journals. And we have Vasco Dracun, did I say that right? Perfect. Digital Operations Officer at Siemens Healthineers. Has more than 30 years of experience. Vasco has dealt hands-on with challenges of adopting and deploying advanced technologies for achieving measurable benefits in manufacturing value chains. At Siemens Healthineers, Vasco is involved in coordinating a strategy and roadmap for digital transformation, applying his experience to some of the most challenging digital transformation projects. Vasco collaborated with Intel, IBM, Hewlett-Packard, Microsoft, SAP, and other leading information systems providers while serving as chief methodologist in Value Chain Group. Dr. Darren Wu, my partner in crime, is Opendoor's Chief Medical Officer, and Darren's coming up on 25 years at Opendoor. I'll never forget the day he started, right? I'll never forget it. He is our senior clinical leader. He oversees the quality of clinical care and service delivery at all of our sites. He directs the recruitment and review of physicians and allied healthcare workers, and he interfaces with our affiliated hospitals. He was, before becoming Chief Medical Officer at Opendoor, he ran our Mount Kisco site, and now he serves, and you were also, gosh, you ran our Rybrook site, or you practicing in Rybrook? Then you moved to Mount Kisco, and you were leading Mount Kisco, and they all fell in love with you in Mount Kisco, and now he's on the board of Northern Westchester Hospital. Darren did his residency at Columbia in the family medicine residency program. So we are, so thrilled that Darren's been around for as many years as he had. But we're here tonight to talk about, sort of artificial intelligence and the impact, we believe the profound impact that that's going to have on healthcare. And so from the development of the personal computer, the advent of the internet, the laptop, the smartphones, right, our lives and world have been changed by technology. And we think that AI is sort of the next step on this digital journey, and it's already all around. Like, I write an email and it finishes my email for me. One example, and I know when Darren and I are busy and we need to get something done quickly, we go right off to ChatGPT and boom, we get a policy, we get a procedure, we get a board report, whatever we need. It provides something very quickly. 1 in 10 cars are projected to be self-driving by 2030. 64% of businesses believe that AI will help to increase their productivity, and 1/4 of companies are adopting AI because of labor shortages. In fact, AI is expected to create 97 million jobs. We're already seeing the tremendous impact of AI. Its market size is expected to reach $407 billion by 2027, and will have an estimated 21% net increase on the United States GDP by 2030. Amazing. So it's just such an exciting time to sort of be involved. It reminds me of, the .com, whenever that was. When was that, in the 90s, or was that around 2000? And so as we think about, kind of the role of AI in advancing health equity, we really thought that this was an appropriate discussion to have with all of you, because obviously our mission at Opendoor is to reduce health disparities. It's very well documented that members of racial, ethnic minorities, people of color just don't fare as well in the healthcare system. And so that's really why we exist. We are in communities where other physicians didn't practice, right, because the resources were indeed so challenging. And so the federal government set up a system of federally qualified health centers just like Open Door all across the United States. And we are a 50-year-old organization, and we're one of 1,400 similar organizations all across the United States. But anyway, back to AI. We're going to talk about sort of the early stages of AI implementation. Darren's going to speak a little bit about, again, we use it sort of in a very rudimentary way at Open Door. Pablo has this incredible perspective as a consultant. He's working all across the sector, and his company, based in Seattle, is really doing some interesting work. And of course, Vasco is using the technology globally, right, in supply chain management and diagnostics. So I guess, you know, the first question, and I think probably we should start with Darren, is Darren, as I said, like, how do you think this is gonna make a difference for us in primary care?
Okay, thank you, Lindsay. So I think AI is gonna transform so much of healthcare actually, and I personally am very excited. I know there's some physicians and some in the healthcare space who are a little worried. It's a very conservative industry in general. However, the issues we face today in Open Door, but everywhere as well, whether you're inpatient, specialty practices, and yes, in primary care practices, access is an issue. Communicating is an issue. How do you bidirectionally interact between providers and patients? Not everyone is as accessible as a couple of clinicians are by email at all times. And AI is going to help that. Right now, those are the stumbling blocks on so many levels. Can't get in to see a primary care clinician, can't get in to see a specialist because of the inefficiencies of the system. It's not lacking for numbers of people. There are some workforce challenge issues, obviously. But I think first and foremost, the increase in efficiency by hurdling over a lot of the burdens of paperwork, filings, documentation, interoperability of information, that will be reduced on the human side with AI, elevating the capability and the capacity of all types of healthcare entities to concentrate on the interaction necessary. So it's going to help with access, it's going to help with the communication aspect. And I can go on and on, I know we have other people here, but so even just managing chronic diseases, reminders on preventive health care, helping patients navigate the system, which is very frightful for everyone in America, even if you have means, even if you have insurance. I imagine you're uninsured, or language is a barrier, or transportation is an issue. AI can actually help things, right? We all Google Map things all the time, Google Translate things all the time. Imagine that expanded into communication and healthcare. And as a primary care clinician, where the breadth of knowledge is so vast, and the depth is not necessarily where we need to be, but the breadth is so important for us to be comfortable with, AI will augment diagnostic accuracy, help clinicians arrive at a faster and more accurate diagnosis, implement treatment plans, and help us follow up with patients on those treatment plans. How are you doing? What are the challenges you're having? All those things right now are such massive stumbling blocks. So it will be hugely transformative for the better, for the majority of healthcare.
You mentioned workforce, Darren, and I want to pass it off to Pablo. I don't know, am I handing you the mic, or is there a mic over there? Because again, I think Slalom is kind of leading the way with some interesting workforce solutions when it comes to AI. If you want to take that one, Pablo.
Sure. So we're in the middle of multiple proof of concepts, really around the world, using digital humans. Now, for adults, that sounds like Star Trek stuff. For your kids, it's just an avatar in a video game. That's really what it is. However, they're very, very smart. A couple of pros about them. They can look like you. So if you're a minority or not a minority, they could look like you. They could be your gender, they could be your ancestry, they can speak your language. In fact, they speak more than 50 languages fluently. So one of the proof of concepts that we just finished actually, and it was expanded. One of the biggest pharma companies in the world is using our digital human for clinical trial recruiting. I don't know if you guys know this, but clinical trials are very discriminating. The vast majority of folks on this planet have no hope of ever participating. So we're using digital humans to recruit people for clinical trials. We're using digital humans to take the place of a clinician, a nurse, in terms of training what's gonna happen during the clinical trial. And also, just now, we expanded that proof of concept to allow the digital human to check on the progress of that person within the clinical trial. Now, we're not eliminating jobs, no. What we're doing is we're liberating those nurses and those physicians to actually focus on more important things. In the human nature of recruiting, you would think, well, use the human's nice. With computer vision, they could actually gauge sentiment. They could actually look at your face through a camera and make the decision that you're sad or you're happy or you're scared, and they can, with the right language model, they could actually adapt to what they're seeing, quote unquote. So that's just one example. I have many, many examples, but it's really cool stuff because that proof of concept that I'm talking to you about, we just finished that last month. And that company came back and said, look, we're going to deploy this everywhere. They have 30 potential medicine on the pipeline, right? And they want to use this proof of concept in 5 of those.
Exciting. Workforce issues. Vasco, can you talk about diagnostics?
Yeah, so I'm gonna take it to another direction, and it's patient. We started using AI in the basically diagnosis level for patients, and about 10 years ago, we were very excited when we were looking at 2D image, could be CT scan, trying to find in that image some hidden clues that doctors sometimes will be missing. Not to say we're gonna do it for you, but to say, okay, here is a second opinion. This is another idea. So things like, for example, looking into CT scan, and you may think that's a penetrating ulcer in the aorta. That would probably be 3 days of hospitalization. That would probably be very quick surgery. Actually, it's congenital deformation in the aorta. So we were training algorithms to recognize the difference between those very peculiar patterns needed to dig. Because that makes a big difference in terms of the treatment and saving a lot of money in terms of hospitalization and surgery. But then 10 years after, just think about 10 years after, we now have fully segmented 3D model of a heart, where we are training surgeons how to operate. So we have just a prototype in UK, Brompton Hospital, that is using some of these methods where basically they say, well, I just get a surgery before I had a surgery.
That's a digital human in essence,
It's
right?
fascinating. They call it digital twin,
Yeah, digital twin.
but it's actually a fully segmented 3D model of a human heart, where you can actually train and then support what am I going to do with this patient before you even open the patient, and understand how this all can come out, in addition to prognosis, planning therapies, and planning follow-ups. But those are the kind of things that AI allows us to do today. And not to think about what can be tomorrow, but just if you think about patients in terms of what we call a vertical model of a patient. Typically, in traditional healthcare, you think about a patient in a cohort. So we are all member of a cohort of 10,000, 15,000 of something. And how we get treated, how we get planned, is however that treatment has been shown in a cohort. Well, now we go with a specific patient. We call it precision medicine. That means give me the data of that patient, the genomics, multiomics, anything we can discern, life habits, everything we can collect. So think about all of us, each of us, how much data is available about us. Think about if that data can be turned into better treatment, into better prognosis, into better diagnosis. And that's what is actually coming up now, is these precision medicine models that are based on AI, developing insights, prognosis, predictions, and scenarios for treatment. And particularly if you think about oncology, or you think about some heart diseases, that's really,
Do you think it's gonna bring costs down? Do you think it's going to make things more expensive? I just imagine all the electricity that's gonna be used by all this computing power, right?
yeah, but a significant reduction in cost.
Right, which ultimately advances health equity. So again, the efficiencies. Darren, you wanna talk a little bit about, again, the efficiencies or just, access to better tools and how challenging that is for us at
Sure.
times?
Okay, so in primary care, traditional primary care is one-on-one relationship, continuity of care with between a panel of patients and a physician or a primary care nurse practitioner or physician assistant. That relationship is predicated on so many things: the hours that the clinician's accessible, his or her knowledge level, communication style, how well he or she was trained, and that style has never been scalable, right? You can have as many primary care clinicians as you can possibly train, and if it's a one-on-one interaction all the time, how many can you do? And you can't achieve enough access to primary care with that kind of model. So that whole transaction type of basis, 15-minute, 30-minute, 45-minute one-on-one thing, it's still to this day what we predominantly do, and that's why we're having such an access issue, right? But if you can use technology, which we already have been doing even before AI has popped onto the radar for us, using the systems that had been non-AI but available, like information databases, which we use before every single session. Every clinician and his or her care team has a huddle. Just like in football, you kind of huddle around my panel of patients coming in, and we are looking at data for every single patient who's scheduled and saying this person needs this person needs that, this person's due for a colon cancer screen, this person needs a pap smear, a mammography, mass blood pressure not well controlled, we have to do better on that. We haven't asked about depression, we haven't asked about smoking. These are all things that right now we're getting from data retrieval. It has completely transformed our care over the last decade, to the point where even I think it was in 2019, we were recognized in the state as the #1 health center in reducing health equities. Because we're looking at the data that tells us, all right, you need this, you need this. Our internal personal biases, which are in everyone, doesn't come into play. Simply, this is what the data tells me you need. And so we actually were recognized that year, not too long ago, as the best in reducing health equity in the state, and since then we've always ranked very high as well. That's going to be more efficient when you don't have databases that spit out information that you have to print, and then have a huddle of team members, because we've got, when I huddle in the morning, it's a nurse, it's a front desk person, it's a medical assistant. We go through the roster of students coming in. Not to say that we don't need our medical assistant or a nurse or a front desk person, but if I can do that with an AI, much faster. Let those individuals do other things. Interact, console, help, explain other things that a human really needs to do. If a machine, if an AI can give me that level of data, it's just going to transform that practice, right? Right now, again, not AI, but for the better part of 5 years, 8 years, we've been using portal systems. That's pretty much generalized across most practices now. And even that has been a transformation in my group, but the way I see it is that has been an access multiplier. Things that you used to have, this is even previous to COVID, to the pandemic, things that we would say, oh, you know, come on in, we need to talk to you, I have to examine you. Why? And there's so many things you can actually just discuss. And you see that now with all these platforms that are like telehealth platforms, digital texting platforms, where clinicians can assess and evaluate things and prescribe treatment without a face-to-face in-person evaluation. It automatically makes things more efficient, automatically scales things better. Now, AI can help those diagnostic algorithms even better. You have a fever for how many days, you have pain on urination, urinary frequency, history of kidney stones. Ooh, probability of a UTI, urinary tract infection, is this. Based on the population in this area and antibiotic resistance patterns and your history, the most likely antibiotic of choice for you is this. Boom. Standardize that, right? Instead of a clinician, variable training backgrounds and experience, like, I think we should do this for 5 days. I think I should do this for 7 days. Imagine that.
Sepsis.
Oh my, sepsis care, right? You want to standardize whatever you can standardize, make that much more efficient, and then use the personal elements of that patient's history, genomics, patterns of resistance that we know about for that patient or for the community, tailor things. How much better is that? So, we've been benefiting in Open Door, just using data without AI, and it has completely improved our care, quality measures, because we are less likely to forget to ask it. As a human, when I first joined Open Door, when we joined Open Door,
Paper.
back in the years, there was paper, 1 out of 4 charts were
Paper.
missing, and then, you were really taking
have
care
nightmares.
of what the person was coming in for, and you can see an individual, time after time, and always forget to offer a pneumonia shot, right? Or forget to talk about cancer screenings, because you're talking about the thing that the patient is concerned about, and our own internal practices and biases, right? But with our data, not yet AI augmented, telling us this person needs this person needs this, our care has just skyrocketed as far as quality and improving health equity. And so I'm very excited when AI will
Go for it.
push this forward.
Yeah.
That's good to hear.
You just reminded me of one thing. So we're working on these 2 projects here in the US, hospital and patient group of the future. And many of the things that Darren just covered, for this one project that we're working on, imagine everything he just said, either the registration being done by a digital human, but fast forward 10 years, and you walking into the hospital with your Apple Watch, and the hospital lobby having contactless sensors to first of all identify who you are, right? We don't want to operate on the wrong guy. 2, it has your comorbidities, right? 3, it has your insurance information, so you don't have to even speak to anybody. But more importantly, that database is available to people like Aaron and the clinicians, so they can much faster. Who hasn't gone to the hospital, to the doctor's office and wait for a long time, right? So that process of figuring out who you are, what you need, how to position your treatment, how to deal with your personality, right? All of that stuff could be done instantly by you walking into the hospital lobby if you have the right technology. So we're working on 2 of those projects here in the US right now. We finished one in Baltimore. And it goes just beyond that. It goes beyond care. It goes into patient journey. For example, this one hospital, real quick. So it's a neurological hospital for children. So most of the time when the child is in that room, the family is in that room, even for many months. So imagine you're in Baltimore and your child's gonna be there for 3 or 4 months. So something as crazy as the dad being there, and the dad, he needs to work. Something as easy as a Wi-Fi password. How many of you have gone to a hospital trying to figure out what the Wi-Fi password is, right? It's like finding El Dorado, right? It's just impossible, right? But imagine a digital human in that room where you can turn around and say, hey, so-and-so, what's the Wi-Fi password? And the digital human telling you the Wi-Fi password. The other thing that it does is that you could order food. Hey, listen, it's not just food from the hospital. You can order food. Right? It has an integration to DoorDash, and if you want Colombia that night, you'll have Colombia that night. The other thing that we taught the model was, let's say that mom wants to go jogging. Well, it's Baltimore. Anybody from Baltimore?
It's there.
Okay, there's Baltimore. So the digital human is able to tell mom, this is the 1 mile radius, and show it on the screen where you can safely go jogging. We'll see you later. All of those things are part of this holistic healthcare. That may not be healthcare, but it's part of the patient journey. It's part of making you feel at ease while your son or daughter is going through some procedure. It's an extension of how you live your life right in the hospital.
I love the idea of the AI digital assistant. I think it's really very exciting, but we talked about this, Vasco, when we met earlier. Again, the underlying data models are, I'd love you to talk a little bit about that, because I know how much we struggle with data governance and making sure everybody enters things where we need them to enter. I mean, this thing is so complicated. At one point, we were fantasizing, saying, well, can read these large language models. it can read, AI is really very smart, we're not gonna even need underlying data models, but it's all about underlying data models. So I'd love you to talk about that, because you had some really interesting
So,
examples.
so Paolo gets to talk about fun stuff, right? So, well, I think without, too much detail, not getting into technologies, it takes an entire data operations to run an AI algorithm. And for most of us who have tried to do it and did it a long time ago and got to the point where we actually can see the fruit of the results, think about a company like ours where R&D expenditure is about low teens of revenue. And out of that expenditure, AI, digitalization is probably 40%. So enough said about how much does it take, but the rewards are huge. So it does pay back. But it does take also a lot of work to set up a proper data operation that allows you to use data with confidence, high quality data, accurate data. Medical data records are notoriously not accurate, not very high quality data, and you want to get into prognosis, diagnosis, and therapy planning, you really need to rely on very high quality data. So that's where the bulk of the cost is in actually creating a very accurate data set. Luckily, there are tools and frameworks. We talk about data governance and some standards, but we are really in the infancy as the industry. We are in the infancy of that part of the equation. So compared to financial sector, where you can have interoperability of data between
Just
a number
numbers.
a
It's
number
only
of
numbers.
services,
Yeah.
right, just numbers. Well, numbers and some other data, but highly interoperable, highly trusted, regulated. And now you're coming into something that used to be, extremely federated environment, where everybody did a part of the work for their own little benefit, not really connecting or understanding what happens next. And that's that uphill battle that we are all now facing, and quite frankly, even a company like Siemens or a big system, healthcare system, much bigger than even Open Door, really cannot tackle on its own. It is almost impossible to consider an individual setup. So it does require a lot of collaboration, and it's gonna require a lot of policy making, and eventually it's gonna require standardization. So in the meantime, there are still some of these exciting possible features that we could do out of AI. Just to kind of expand it a little, everybody's now talking about AI, generative AI and ChatGPT. Think about it really from a reality point of view. It's almost like a solution looking for a problem. And the approach in the healthcare has to be, what is the right solution for the problem? We have to approach it from the problem point of view, and not from this giddy NVIDIA, Microsoft, everybody now has. It's all really based on the extremely affordable computing power. Because these days you can buy for $1,000, which is exponential. We all know that computing power cost is exponentially decreasing. So these days for $1,000 US, you can buy computing power of a human brain. Just think about it. And it's exponential, which is 2 years, 3 years ago, it was a fraction of it. And it's actually gonna get even better, not to think about quantum computing in the next generation. So it's always that exponential growth in the computing, which by itself is just data, is just the power. Well, it has to be orchestrated, it has to be organized. And in terms of AI, the key is data. So Lindsay, you're absolutely right. And that is, we are in the infancy, but I think what Darren is talking about is quite possible. And it can create these effects of talking about affordable care. How many of us can get, unless you can go to Walter Reed, who's gonna get a consilium to take care of them? But in this kind of setting, any patient can get, a couple of artificial advices and side advices and doctors and second opinions, and it could be like, let's look at the patient from one angle or another angle and a third angle, which is what you're gonna get from a consilium of doctors, but not in an affordable care setting. So those are the type of things that are possible even with the data that Darren is dealing with. And then the question is, why not? Why wouldn't we start there? But we still need to deal with the data. That's
So-
gonna take a lot more than,
The promise of AI, I mean, it's so exciting, but for those of us in the business, I'm looking at Bob, we had this like rather large problem 2 weeks ago, Change Healthcare, right, which is United Healthcare Optum affiliated company that basically does a lot of the pharmacy transactions and many of the claims processing, and it kind of shut down a lot of healthcare operations all across the United States, to the point where the federal government had to get involved and was advancing cash. Fortunately, it didn't impact us at Open Door. We use another clearinghouse for our billing. But, it provides, the example of all the cyber threats, right? So I kind of want to talk about the negative side, as well as some people are really afraid of AI and think, potentially, you talked about the human brain. Well, there are some human brains that are not as nice as other human brains, right? And so, could the technology be co-opted for, nefarious purposes? We should talk a little bit about that. Go for it.
Alright, so let me just calm you guys down. AI is not taking anybody's job. However, this is how you have to think about the difference between the human brain and what Vasco and I work with every day. Think about a human toddler, 2 years, 3 years old. That toddler, if you show him a couple of cats, different types of cats, 2 or 3, he will be able to identify any kind of cat, even a stuffed animal cat, just by showing him a couple. That's the way our brain works. Computers don't work that way. You will have to show him every single possible cat and then teach the model that this is a cat that is alive, it's not a tiger, and this one is a stuffed animal. So there's still plenty of years ahead for the technology to catch up to how we think. Think about this too. You break up with your girlfriend, you're at a bar, that happens to a lot of us. And there's a new girl, right? There's a new girl. And your brain eventually is able to process the fact that the other one is now gone and this is your future, right? Computers can't do that. So the creativity piece, still for the time being, is still with the human brain. Now, to your question. Cybersecurity obviously is extremely important. All of those people you mentioned, they're now my customers, so I'm not surprised. Just kidding.
Help!
Just kidding. But what Vasco was saying, right? AI wouldn't exist, it wouldn't be useful without the data, right? And we're talking about large amounts of data. So part of the governance has to be data security, access. Not just HIPAA, it goes beyond that. We're talking about this holistic view. Right? We're talking about your social media profile. We're talking about your zip code. Your zip code tells us a lot about who you are, right? What you post on Twitter, all of those things, right? If you talk about all of those kinds of data that are readily available, then no one is actually securing. We're also, when Vasco and I talk about an AI model being able to learn, we're also talking about those pieces of data.
yeah, well, cybersecurity is definitely a big threat, huge threat, and I don't think we have adequate solutions that could be widely deployed to go a step ahead, because think about generative AI in terms of ransomware. Generative AI can create an email that looks almost identical to the email you would receive from your bank. It can even hide, and it has increased the throughput of these malicious software codes tenfold, if not 100-fold. Because people are now just creating very bad code very quickly in very big numbers. So as much as it works on the good side, it works on the nefarious side as well. And for us to kind of tackle that issue more proactively does require risk management, does require really good awareness of where the cybersecurity risks are, and then to some extent, some incentive to those weak links in the entire chain to take care of those risks. To some extent, you can think of it as okay, payers cannot pay, then everything stops, then you cannot provide a service. So that's a big value chain where every weak link can stop the next one. Our concern, for example, in Siemens right now is our suppliers, particularly unique suppliers that we cannot replace, how vulnerable they are to ransomware. And they're probably not gonna come to our fortress, but any ransomware player can stop a small supplier. We have a lot of small suppliers. And who they gonna ask for ransom? Not the small supplier, they're gonna ask big companies, because they have to have business continuity. And digital component of business continuity is huge. So those are all now connected vessels, if you wish, that we have to address holistically, and we cannot really deal with them one incident at a time. So these risk policies, risk sharing, bringing that risk profile into the deals, into the contracts, into evaluation. We had a case, I think there was another one, Delta Dental.
Yeah.
Move it. You probably forget with Move It software, and everybody just send a letter. They say, "Oh, somebody stole your data," and it's not us; it's the Move It. That has to go away. You know? So think about in Europe, there is a new regulation coming, NIS2, where they're actually placing that responsibility square on the company providing the service. No more excuse, my supplier is guilty for it. So that's the kind of regulatory framework that we also gonna need to make sure that all players in the value chain are equally responsible and responsible for their own part. And you just cannot pass that risk downstream all the way. In some cases, could go all the way to the patient. So think about somebody hijacking personal data and changing the personal data. And there it's just about to plan treatment, and tomorrow that's not that same patient. Because somebody has just switched the data because they can do it. We cannot afford that.
May I?
Go for it, Sue.
This may be for more Darren than anybody else. This is so interesting. But let's say I'm an open door patient. None of this matters to me. What matters to me is who's my soft handoff, who's gonna talk to me. So can you talk a little bit about how this translates back that way?
I'm gonna have Darren do that.
Sure, okay, but you know, before I do that, Sue, if I may, so we were just notified by our one of our credit card companies last week, you know, are these charges yours, my wife's credit card? And I can only imagine it was some sort of AI processing algorithm that picked up that Betty Wu never shops at this place, boom, 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 boom. And they contacted us and put a stop to the credit card. So I think there will be always really devious, unfortunately, very intelligent people trying to game things out. And that's just gonna continue to happen. But on the other side, there's gonna always be very smart people with reasons and incentives to keep creating parameters and guards and alarms and stuff. Because we would never have known the card was stolen except for something alerted us
That's a risk.
because of that, right? So I think that's just one imperfect example, but I imagine other iterations will happen. So Sue, I think just like what I was mentioning before, I have seen, you know, how we've improved over the 2 decades of care by willing to embrace and change ourselves, our workflows, increase the use of team, increase use of data, technology, basic technology that other industries have had for decades, but healthcare is always slow to adopt things. And it just keeps on expanding our capacity. So when you go from 2 or 3 clinicians and you use the same traditional ways of things, you're just increasing your throughput from 2 to 3 times. But if you're using technology, you can amplify that, magnify that several fold. We've done that in our humble way in Open Door. So while I am quite spooked by the potential bad things that can happen, and I don't think we can ever discount that, the simple improvement for population health, the human condition, the net positive, I think is so much greater that we have to keep exploring these areas. Because right now when you call, never mind just us Open Door, but any of our fellow peers or competitors, how long do you have to stay on the phone? How long does it?
Yeah, it's torture.
With an open door?
What do you guys?
Right, so how long does it take? How long does it take to get registered? How long, and if there could be algorithmic interactions, right? What kind of symptoms are you worried about? What, and information that can be retrieved about your past medical history, perhaps from an Optum practice, that's not an open door practice. But if we can integrate that information before a human registers you, we can say, oh, this person needs to be seen now. This person we should prioritize maybe tomorrow. This person really is just looking for a physical exam and we wish we could do it today, but why don't we make that next week? So right now humans are imperfectly making those decisions. And that simple change would really improve healthcare at our level.
Wow.
If I may say, yeah.
But this is a digression a little bit, but I think those of us that use Optum at the moment are frustrated with how big it's gotten and how impersonal, and you know, and that physicians are expected to see patients for 10 minutes at a time, and that's it. And that they're not even allowed to schedule, they're no longer allowed to keep open same-day appointments for people who are actually sick, because they're being required to.
Yes,
Urgent care?
Yeah, go to urgent care instead, you can't actually see your doctor.
yes.
So when you're talking about the virtual human screening, you know, I think there's a place for that, but I also think people are really missing the personal piece
Yes.
of medicine.
Yes. Yes, so I firmly believe this. I do think AI will be somewhat of a disruptor. There will be changes throughout the industry, multiple lines will be affected. The overall product that we all want as consumers of healthcare is going to improve. But nothing is ever going to replace that need we have for that human interaction, that reassurance, that empathy. That machine cannot necessarily give. It can recognize, but maybe not give. Or if there are multiple treatment algorithms that are computed to be suitable for you, which one is still best for you based on your concerns, your fears, your preferences, your resources? What is the best one right now for you? Maybe a computer and AI can help narrow that down, but in the decision, at the final analysis, it's going to be that interaction between a clinician you trust and yourself, right? You have to pick something. So I think we're always going to rely on that human interaction to finalize what is most important to me, for whatever it is I'm looking for, whether it's healthcare or some other industry. And the things, just going back to what you're saying, this the difficulty in accessing care, that's many places right now. And I guarantee, I firmly believe this is because humans do not know how to deal with the demand that's coming in. I think an AI type of system would help us filter through the data and say, all right, we don't need to fill up our schedules with these kind of patients, visits or questions. That could be taken care of by boom, 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 or virtual care, or a digital human. But this person who is describing these set of symptoms and concerns, and based on his or her history, get her in now.
Yeah.
Right? But right now, humans are making those decisions, and we're very defensive. Humans are very defensive.
Jane, so the way we have helped some hospitals, there's a big hospital chain up in Massachusetts. What we did with AI for them was we built this AI forecasting engine for operational KPIs. So for example, the AI model would try to forecast when they were going to run out of beds, in what hospital and what practice, 7 days in advance. So what that did for them is it gave them the ability to plan and triage better, exactly what Darren just said, but with the AI forecasting. It's pretty accurate, and they're going to expand it actually to all of the hospitals. So that's one way that AI can help to make the doctor available to the right person. The other thing that we did, a pretty cool POC, still in POC, is a chatbot where you can chat through WhatsApp to make an appointment. And we threw some level of triage into it. For example, if you chat and you say, I need an appointment, I cut myself, right? Part of the model was to turn your phone and take a picture of the wound and send it to the AI engine, and then the AI engine say, that looks pretty bad, come in right away, or you're just a baby, don't let me call you. So it is those kinds of things. But I will say this, where we are right now, a lot of the dollars and a lot of the proof of concepts are really in oncology and some pretty massive diseases. Not necessarily in primary care just yet.
Please.
So, if we're talking about equity, we know there's a huge issue with digital equity between the patients you serve and people sitting here in the room. So, if people don't have access to the digital tools that they need to use what AI has the potential to offer, how do you make it accessible? You know, here in Westchester, low-income people don't have internet. There are all sorts of programs to get internet, to get tools, to get tablets, to get computers. Like, people don't have that are low income, or they don't have it in as a robust a way. I mean, we saw that in COVID with learning, with so many things. So does AI have the potential to make things even more inequitable because people can't access it?
It potentially could. We are in the risk benefits industry, and convincing that benefits are higher than risk takes effort. And I think if you look at the potential for AI focusing on a particular patient rather than an administrative rule that looks at the cohort of patient, this takes 10 minutes, this takes 15, and then you have to live in those boundaries because that's how administrators think. They can preserve the budget. We have to still convince the administrators that focusing on the individual patient is actually better. Enabling that patient digital means of communication is a good investment. Creating investment in data security, cybersecurity is a good investment. Why? Because all these benefits are real. And this is where I think we are now stuck a little bit, that we don't really understand who has to invest what and where to create that type of ecosystem, that type of environment. So at this point in time, I think it's really about initiating the investment at some level, creating the use cases, capturing the returns, understanding that and presenting that as a business investment, and not just, any kind of social type of thing. These are big profit-making potentials.
Just to also share, we know from models around the world that in countries that may not have a lot of resources, putting mobile phones and cell towers, which are fairly basic technology now, even though the computing power in a cell phone, right, can exceed that of the space shuttle. And so in countries that may not have a lot of infrastructure, large parts of India, large parts of the continent of Africa, they've been able to just deploy mobile technology, and they are plugged in. So I think in a country like the United States, where the infrastructure is actually vastly better, it's simply a decision. It's simply a decision of how we want to deploy, because for here it can be easy to make deployable technology more accessible to individuals. And we actually did a study not too long ago, just because of this very concern, like, can our patients get onto the portal and communicate with the clinicians? And we found out, yes, they can. So a lot of patients will not actually have a laptop or an iPad, but almost all of our patients have a mobile phone. There are still issues, depends on the bandwidth, depends on where they are, depends on the minutes run out towards the end of their cycle, so that definitely is a barrier, and that health equity can be impacted by that alone. But they largely have a mobile phone. That's how they come to us. They're Google mapping their way to Open Doors facilities. And so this technology that has become democratized around the world. I mean, can you imagine 20 years ago, the capacity that we have now in my pocket? It's incredible. It's a supercomputer. Our patients have that. There is still a gap sometimes in bridging that digital literacy, but the digital technology access is largely available.
Can I add two things to that? So Jen, so the chatbot that I was talking about also works off a landline. You could actually talk to it. So that's one thing. The other thing that I was gonna say was, this whole aspect of the patient journey that we're talking about, right? It could be, there are ways of handling it. One of our customers did this trial where it was about diabetes, right? And it's in the inner city where folks sometimes don't have Wi-Fi. And that was one of the problems. They did this beautiful mobile app, you know, for you to talk to a nurse, and no one used it because no one could use it. So what they came up with was a device that anybody could plug into a power outlet that has Wi-Fi. So you don't have to call the cable company. And that device actually also had Bluetooth, and it was connected to some of the devices that they use. For example, somebody has diabetes, maybe in the morning when they wake up, have to get on a scale, right? If you're an older person in the inner city, you don't want to get on the scale and then call the nurse to tell her that you have gained weight. So the scale recorded your weight, and through Bluetooth, talk to that device that you plugged in, like an air freshener, and send that information to the nurse. Voila, done. And what I'm talking about, I'm not talking to you about millions of dollars. These devices are less than $100. So, and by the way, that customer is here in New York. So there are ways to handle that inequality.
Please, Bill.
So you mentioned before, one of the big gains in AI areas is oncology. Where are we with AI reading scans so that from one doctor to another doctor, you don't have to get to the best doctor, but anybody, you know, in terms of equity, anybody can get the, you know, state of the art because of AI?
We have a customer. And by the way, don't buy stock shares, that's what I'm saying, or sell stock shares. I'm here to record. So we just finished this POC, and you could Google this. This is public information. There's a company called Signomics. We just did a POC for exactly that, right? But it's an interesting POC because it was successful. We used, with the first data set, we were 70% accurate the first time. And obviously the more you use it, it gets better. But it was exactly what you just said, being able to look at a slide, look at a chart, and being able to say, hey, instead of looking at this 100,000 cells, it's gonna take you, 4 or 5 hours, look at this cell, and this cell. Those are probably the ones who you should be worried about. So we completed that POC. We thought it was gonna be, people were gonna be like patting us on the back. And I remember we had this conversation with them where the regulations are just not there. So if they were to deploy this, they would lose money, because the reimbursement rate for a physician to look at a chart and a machine to look at a chart hasn't been defined yet, right? So if no human looks at a chart, that you get reimbursed at a very low rate, $2 versus $40.
So I mean, that would get solved. So I mean, in terms of technology, I hear you saying today, that's a problem. But just in terms of the ability of AI.
The ability is there. The ability is there. We have multiple POCs around the world that do just that. And actually, if you could Google Siemens, they do this with radiology now. This is going on right now.
And is it to back up the doctor, or is it to?
It's a backup to the doctor.
So it's
Yes.
a second opinion, or it's to direct the doctor where to look?
Both, but more so, what it does, for example, with cervical cancer, 90% of cases of cervical cancer around the world are in third world countries, right? So with remote diagnosing and being able to see a chart from, I don't know, Zimbabwe, and being able to run it through the AI engine and present it to a doctor in Mount Kisco,
That's cool.
that exists right now, and it's being done right now.
We have a question.
So should radiologists be concerned?
They're using it.
No, they love it. They love it. It increases their confidence.
Just a couple of quick thoughts and reactions from me. So, AI is clearly gonna have huge impacts. It already has for the past 10 years, and people don't even know it's happened to them, but it's there and working. And the risks you pointed out, data structure, data purity, cyber risk were all really important. But we did learn some material lessons from social media's rollout in this country and around the world. And we did two things I think pretty bad, which could happen to AI. One, we did a poor job of educating the users of what this tool meant. So you're gonna have, like in healthcare, you'll bring AI into the equation, and if the patient doesn't know what to do with it or how to react with it, it will not be as much of a success story as it should be, right? Because you may tell me, I'm gonna give you to a digital, person to deal with your situation, but if I don't know that's the right path, and I don't know what to experience, then that's a concern. The other concern I have is financial. And I think there are two big sort of, what I'll call elephants that you gotta deal with. The first elephant is the insurance industry. And how are they gonna take advantage of this to pay out less? Because they will. They'll figure it out, that's all they're there to do, is to pay less, which squeezes the industry. You just brought it up on the image. If the machine looked at it or AI looked at it versus person, I'm not gonna reimburse you. But then you also get into an emerging trend that's happening in healthcare. Huge amount of private equity is coming in, and they're squeezing the living hell out of it. And so AI is a very important tool to not negatively impact the care model because of cost takeout before productivity tools like AI is already there. Does that make any sense to you?
It does. If you look at three macro trends, I mentioned one, which is exponential growth in computing power for the same amount of money. And that's since 80s. It hasn't changed, it will probably continue.
Yeah.
The second macro is GDP, corporate profit. In early 80s, corporate profit of 4 or 5% was considered great. Now we're getting into high teens, and it's not enough. Constantly, linearly growing up. Household income, real household income since 80s, flat. We are in the industry where we have to get people to pay for the services. Where are they gonna pay for them? So just think about the three trends that we all know. They just Google them and figure it out. It's right there. So some fundamental changes have to happen. If the expectations are that corporate profit, even my company or insurance, right? If the expectations are that these corporate profits are gonna go up, while people cannot pay for anything anymore, that's gonna be a collision. Some real fundamental changes have to happen, and some of the critical changes with technology were always happening through standardization, creating basic infrastructure out of this. Why is data not a basic infrastructure like water?
Absolutely.
So we're gonna have to get to that level of solution, but doing it in segments and partially, one case at a time is probably not gonna be practical, but in the meantime,
And have
we
we
can help
brought
people like
any
that.
malpractice risk into AI?
Oh, that's-
Uncharted waters.
I tell you, there'll be another chip, and that's gonna be 10 times faster,
Oh, yeah.
for sure, and somebody's gonna take advantage of it. So you are absolutely right, that those forces will never change. The question is the equity, the question is affordability and equity. Are we going to turn those advances into something that's equitable for all participants, particularly for the patients?
But could I do a reverse issue, because I've lengthened the life of every person, because AI has introduced better healthcare, I therefore have an affordability or the inability to sustain it.
And that's the best we can do right now, is kill people like Darren. He has use cases, concrete use cases that can right now, right away, help.
Yep.
And actually return the US. And that's where I think we should be start nibbling at this problem, is one use case at a time. Understanding one project, one return, one investment, and start to achieve those results. But in the meantime, eventually the treasury is gonna get to the point where something big is going to happen.
So hopefully policymakers are thinking about this. Oh, yes, questions?
Yeah, I had a question on Sal's point, which I thought he made a really good point. This is a question for Darren, but if Darren, you have these tens of thousands of patients and you get this data, I mean, now you know with these underserved communities, you know what kind of data, what they may see health-wise, what they may see in their future, what they may be, whether it's renal or vascular or some sort of comorbidity that they're gonna be experiencing. So you get this data from Pablo and Vasco. How do you, to Sal's point, how do you get to the nutritionist, all the different doctors in your system to say, hey, because, you know, there was always that thing when we were kids, it was, you can call me now, or you can call me later. But to Sal's point, like, how do you get the message across to, today with all that data, how do you, for proactive and preventative measures, how do you get the message across to your patients?
What a great question.
Yeah, across patients and also to our own staff. Right, you know, and I've been thinking about, as I'm hearing them talk about these incredible things, which is just, to me, just exciting, so sorry I'm shaking a bit, but, I still think that when I look at, the needs, the population, just strictly population health, maybe not boutique care, concierge care, for-profit care, but just population health. The need is tremendous in this country, in this area, right? So in Westchester County, one of the wealthiest places on earth, almost 15% of people do not have insurance. And there are massive health disparities. When we meet with the Department of Health, you have 100 times the rate of some sexually transmitted infections for one demographic compared to another in this county. And I think of all my colleagues who've been like, oh, why are you bringing in so many, and I'm sorry, I'm going to some information that may fluster some physicians, but like physician colleagues, like, why are we bringing so many nurse practitioners and PAs? My response is always, we need all hands on deck. We need access. We need everyone who is willing to see patients, and it's never stopped the need. We've hired so many physicians, NPs, PAs, and the need continues. I need technology so we can reach out more. And when you're able to take care of people, and your data shows it, then the model is of interest to other people. We've opened up sites in Albany, we're exploring other places, school-based schools districts are asking us to open up things because the need is tremendous. And you know, we often talk about the tremendous growth of Open Door, and Lindsay's stewardship is phenomenal. I think besides that, the primary need why we've grown 7-fold is because of need. The need is tremendous. And FQACs, which were, I didn't even know what it was when I joined Open Door. I did not even know what an FQAC was, and now there are 1,400 in the country because of the need. So I am biased when I think about the enhancements in access and diagnostic accuracy and treatment by the communication. Communication, that is so lacking in healthcare. The power to improve so many areas that right now cause so much consternation for patients, clinicians who want to reach out to patients, but it's not efficient and it's imperfect. When I have data and I'm trying my best to think of what's the best treatment plan for my patient, I would love technology to help me. I'm not worried about job security. I see the need as not infinite, but it's just tremendous. And we're scratching just the surface right now, even in the
Just
FQHC
mention
world.
prevention.
Sure.
And
Yeah. Okay. All right. So on the prevention side, and I mentioned before how in Open Door we used to not really focus enough on prevention because you took care of things that the patient was worried about. When they came in and this hurt or have a cut on the hand, you took care of that. Transactional, almost like urgent care, and then come back when you see us next. We're missing all sorts of things, right? Now with data and the emphasis on preventive care, much better diagnostic capabilities to find colon cancer early, right? Find breast cancer early, find cervical cancer early, and that's just the start. There's so many other things we need to engage everyone in. What is my diabetes risk? If I have diabetes, how do I prevent it from getting worse? What is my renal failure risk? One of the things I often tell Lindsay, like, just seeing the information of our patients, we see the renal risks rising across Open Door, especially escalated since the pandemic. Liver function tests and kidney function tests are rising, worsening. How do we get technology? Right now we'd have to create a registry, have someone looking at the data, tracking things. Oh, this person's rising, hasn't had a follow-up appointment. Reach out, try to reach out, bring them in if we have capacity to see the patient. But if an AI model can like automatically track these things, is it, trend is rising, prostate-specific antigen is rising, A1C is rising, anemia is worsening. Before the patient is even feeling symptoms, before I'm seeing data myself, right? How important is that? How wonderful would that be? And this is just partly a joke, but I'm just thinking, like, I've been saying this for 20 years. I would love to have the perfect test would be a diagnostic capacity in my toilet, so that when every morning we all get up to pee, we all do, right? And they can say, "Oh, you're dehydrated. Ooh, your vitamin C levels. Ooh, you're having fun. Ooh, how cool would that be? I mean, that should be easy.
Darren, this
to do.
exists.
That should be easy, right? And then it should just, that information should just go right to some center and go, oh, let's get that, or at least send a digital text, how you doing? Did you drink some more water? Did you drink too much alcohol? Were you at an event last night? That kind of stuff. This stuff would just make health better. I see the opportunities as tremendous. The risks are there too, but the overall net positive, I know that's imperfect for me to say that because I don't know all the details, but I just see what is not being done, what is not being headed off, what is not being prevented, when we should be able to.
Can I add something to it? So, Ken, the other thing that excites me about this is multiplying exponentially what Darren just said. So imagine going back to digital human, but don't think about it as a weird avatar on your TV. It's on your phone, right? And because of this data, because of this 360-degree view of your health, mental, physical, etc., we know your nutrition because your phone has a camera and it sees you eat, right? And
Oh my God.
And this life coach, your digital life coach, can remind you, hey Ken, this is your third drink, and your liver is already in bad shape, right? Or this is your third serving of chocolate cake, right? Things of that nature. Or you have diabetes and you say to yourself, well, I'm not eating anything sweet, but you're eating tons of rice and pasta. Well, guess what? It's the same thing, right? Once it gets into your bloodstream. So all of those things that
Lord, did you just give them my?
we have been
Everything
following.
I eat and drink.
We have been following you for weeks. So if you think about that, if you think about technology being able to support you that way, I mean, it happens to me, like I go to the ER, for example, I have an infection, they give me the antibiotics. The minute I leave the hospital, I'm walking to my car, I no longer remember how many pills I have to take, when I have to take them, do I eat before, do I eat after? But imagine having an assistant on your phone that says, hey, Pablo, at 12 o'clock, you gotta take 2 of these pills, do not eat before. You're good to go, right? So using that information, using digital technology to try to get you whole. And your phone has a camera, it could also sense sentiment. When you're down, it could also see that, right? So your digital assistant will be like, hey, Ken, why are you down? What are we doing, right? Eventually, we're gonna get to that point because health is not just what happens at Open Door, right? It was what happens 24/7.
Terrific. I think it's a wrap, right, Elizabeth? Thank you, everyone. Thank you, Laura.